Dear Chairman, ladies and gentlemen, now I understand why Dr. Birlakis put my lecture after the excellent lecture of Dr. Milano, because the treatment of the first shoulder dislocation is the best treatment to avoid all these complications that Dr. Milano presented to us. And normally, everybody, after, the usual treatment is reduction, immobilization, rehabilitation. Everybody is doing it. The knowledge of this lecture is for all the orthopedic surgeons. But we have to differentiate between the patients. There are young patients, older patients, they are athletes. That means that they are doing training 3 times in the week and they have a game in the weekend. There are weekend athletes, and there are the normal population. They don't use very much their upper limbs. But there are many people, they are at high risk of redislocation after. And here you can see a statistic. There are papers. Okay, the redislocation rate is between 17 and 90%. That depending of the activity and of the age of the patients. And now we begin from the pathology. What do we have? We have Bangert lesion, slap lesion. That means always we have to perform an operation. Hill-Sachs lesion, capsule overstraining, slap, and 2 times. And that means after a first shoulder dislocation, the patients get a shoulder instability. It is like after ACL injury. We have an ACL injury, and slowly we have an knee instability. Here we can look, what does it mean? It is also like in the knee, in ACL injury. After the disruption of the anterior capsule, you can see the center of the head is not in the center of the glenoid. It is like an anterior displacement of the knee joint. And that means in some years, these patients will get an osteoarthritis of the shoulder. That is the first point, because the movement is very pathological. And we have this Bangert lesion. You can see it is the capsule is far away from the glenoid, and it is better to have to reestablish the real anatomy of the shoulder joint. And also, if you have this slap lesion, it is very difficult for the patient. Sometimes these patients, they have a redislocation during in the night when they want to turn during sleeping. And sometimes it's a little close, but it doesn't mean that this shoulder will be stable. And also we have the Hill-Sachs lesion, which makes also additional problems, as very well Professor Milano said to us, which is the physical history of traumatic shoulder dislocation. After some time, we have here a healing. The capsule is far away from the rim, and it is like, and it is very easy for the head to come forwards, even if it is not, there is not a dislocation. There is a light movement which pushes the patient to avoid many things in daily life. That makes the quality of the life of the patient very low. Sometimes, for example, okay, here we can see the redislocation rate after conservative treatment. Sorry. here is a very interesting paper. You can see we have a redislocation rate. This is very high in this age, between 20 and 30, and also between 30 and 40. And this age is very much at risk. There is another very good paper, and we can see that all the patients younger than 30 years old, the risk of re-injury is very high. These people are very good candidates for stabilization after the first shoulder dislocation. And there is also that if we leave the patient and the patient had a third dislocation, that it is very critical. At first, because you have a very big damage in the anterior side of the joint, and also the third dislocation is a bad predictor for a good result after stabilization. Also, even if you do not do after the first shoulder dislocation an arthroscopy, please do it after the second. Don't wait after the patient has a third shoulder dislocation and then he is convinced to undergo an operation. And also, the bone loss is, at first, we have a very mild bone loss in 40% of the patients, but later we have moderate to severe bone loss in 86% of the patients. And then, after the arthroscopy that we have all these tools now, it is very easy to convince the patients to undergo an operation, an arthroscopic operation. And there are 3 very good papers to show the differences between these 3 groups that I told before. There is a very good paper from this paper is about a group of students, that means normal population. This is about cadets, and this is about rugby players. And you can see after conservative treatment between students, we had a 50% recurrent rate after conservative treatment and only 16% after arthroscopic treatment. And here by cadets, the cadets, they are not really athletes, but they have to do many things more than normal students. After conservative treatment, we have 75% and only 11% after arthroscopic treatment. And here by athletes, really professional athletes, all these athletes have to be operated, otherwise they cannot play. And in the group of the normal population, the quality of life is lower, because all these people, they do something like after ACL injury. They go down with their level of activity. And sometimes if someone is a student, he can do it because he is busy with his study, but later when they are 30, they get married and then they have children, and then they want to speak, to play with their children, and they come back and they say, I want to be really healthy to follow my children playing this or doing this and all these things. Also, we have to say to our patients, even if they say also, I will avoid this activity, I don't want an operation, we have to say, you need it because you are a young guy, by 30 you have all your life before you, and you need to be very healthy. And so after first traumatic dislocation, always in younger patients, they are athletic active, we have to perform an arthroscopic repair. And I have to say, from my experience, that this arthroscopic procedure in the shoulder joint was for me the one of the, it was the easiest for me operation during shoulder arthroscopy learning. And so I have to say that always we need to say to our patients that a first shoulder dislocation is something which has to be operated. And then we have to say, perhaps it is not necessary for you, but at first we have to think about that it is, we need an operative treatment. And I began in many years ago, 15 years ago, and since then I do it always, or at least I propose it always, because there is a high risk of redislocation, and there is a high risk of arthritis, and also it is a danger for many people, because I have people, they come to me and to be operated because during swimming they had a redislocation that can be dangerous for their life. And so the modern techniques allow us to do very easy this operation, and we have to propose to our patients in the same ways like we propose to our patients to be operated after an ACL injury. Thank you for your attention.